State facilities were the best treatment option for those with mental illness for a long time, and patients were there for months or years. The 1950s brought psychotropic medications and some success in treating symptoms. The 1970s brought a focus on patient rights and changes in commitment laws, which led to deinstitutionalization. Institutions could no longer keep patients indefinitely, and people had to be treated in the least restrictive environment possible. Today, patients are treated in a variety of settings. Inpatient hospital treatment. In the 1980s, inpatient hospital treatment was still the primary mode of treatment for mental illness. Talk therapy, milieu therapy, and one-to-one interactions between patients and staff were typical treatment. Individual and group therapy focused on trust and self-disclosure. Effective milieu therapy required long stays as the more stable patients provided structure and support for the new patients. In the 1990s, healthcare began to change and the length of stay shortened to a few days. Patients came in sicker and have shorter stays, which means that the units have to provide rapid assessment, stabilization of symptoms, and discharge planning. Goals must be accomplished quickly. A patient-centered multidisciplinary approach is essential. Clinicians help the patients to recognize their symptoms, identify coping skills, and choose discharge support. Then they can identify long-term issues for the patient to work on in outpatient therapy. Short inpatient stays can be as effective as longer hospitalization. Those who spent fewer days in the hospital were just as likely to attend their outpatient programs, were more likely to be employed, and to have improved social functioning. They did not have disjointed care or more frequent hospitalizations. Long-stay patients are those with severe and persistent mental illness that continue to need acute care even with the emphasis on shortened stays. The patient populations usually include those who were hospitalized before deinstitutionalization, those who have been hospitalized consistently for long periods, and those with difficult behaviors. This includes our state psychiatric hospital population, and we have 5 currently and soon to be 4 as LaRue Carter is closing in March. The UK and Canada offer hostels for some of these longer-term patients. The hostels provide access to communities and are more home-like. The patients cook, clean, and do housework. Reports show improved functioning, fewer aggressive episodes, and increased satisfaction with care. Some remain in those settings while others return to the community. Case managers are usually either nurses or social workers who follow the patient from admission to discharge and serve as a liaison between the patient and community resources. They work with the patient to make sure there's follow-up care after discharge and that they're able to get to their appointments. Discharge planning is based on the individual patient's needs: housing, transportation, medication management, follow-up care, etc. Some roadblocks to successful discharge planning are drug and alcohol use, criminal or violent behavior, non-compliance, suicidal ideation. Successful planning needs to include education on relapse to both patients and their families. If they can recognize signs early, they are less likely to need hospitalization. Partial hospitalization programs are designed to help patients make a gradual transition back to the community. Most programs include groups for building communication and social skills, problem solving, medication management, and coping skills. Each patient has an individual plan that's developed by the treatment team with 8 categories of goals, and those categories are stabilizing psychiatric symptoms, monitoring drug effectiveness, stabilizing the living environment, improving ADLs, learning to structure their time, developing social skills, obtaining paid employment or a volunteer position, and providing follow-up care. Residential treatment settings are in the community and vary according to structure, level of supervision, and what services they provide. Some are transitional with the intent that the patients will transition to more independent living, and some are longer term. Group homes typically have 6 to 10 residents who take turns cooking meals and share household chores with 1 to 2 staff members. Supervised apartments typically have 2 residents per apartment with staff available for crisis intervention, transportation, and other needs. Board care homes typically provide a room, bathroom, laundry facilities, and a shared meal each day. Adult foster care may have 1 to 3 patients in a home-like setting that includes meals and social activities with the family. Crisis or respite care is short-term during a crisis when the patient needs help coping. They may feel overwhelmed with their living situation, or they can't cope with the emotions that they're having. The evolving consumer household is a group living situation where the residents transition from a traditional group home to a residence where they have their own responsibilities and function without on-site staff supervision. One problem for those with mental illness is frequent moves as they transition from one level of care to another. This can cause a setback to their progress. The evolving consumer household is a permanent housing situation. Psychiatric rehabilitation refers to services designed to promote the recovery process for those with mental illness. Recovery goes beyond symptom control and medication management. It includes personal growth, reintegration into the community, empowerment, increased independence, and improved quality of life. Psychiatric rehabilitation has improved patient outcomes by providing community support services that reduce readmission rates and improve community integration. However, managed care has reduced the medically necessary services that get funded. Skills training was found to help patients in the community, so managed care might pay for that, but not other aspects of rehabilitation, like socialization or environmental support. The clubhouse model was pioneered by Fountain House in New York City in 1948. There are 300 clubhouses in 33 countries worldwide. Fountain House is an international community based on the belief that people with serious and persistent mental illness can and will achieve normal life goals when given the opportunity, time, support, and fellowship. There are 4 guaranteed rights of members: a place to come to, meaningful work, meaningful relationships, and a place to return to. There are many opportunities with the clubhouse model: work, leisure activities, employment support, and housing options. It recognizes the physician-client relationship is key to successful treatment and rehabilitation. The clubhouse focus is on health, not illness. Members make their own decisions about treatment, taking medications, and whether or not they need hospitalization. One of the most effective approaches to community-based treatment is ACT, Assertive Community Treatment. This idea was conceived in 1973 in Madison, Wisconsin, with the idea to provide skills training, support, and teaching in the community rather than in the hospital. ACT has a problem-solving orientation. Staff help with life issues no matter how small. ACT also provides services directly rather than referring them out, and they are implemented in the person's home or community and not in an office. ACT services are intense, 3 or more face-to-face contacts that are tailored to the client's needs. They use a team approach that allows all team members to be familiar with all clients, so clients don't have to wait for an assigned person. The commitment to the client is long-term. Services are provided as long as there's a need, but they do transition to less intense services. When compared to the homeless without mental illness, the homeless with mental illness are homeless longer, spend more time in shelters, have less contact with their family, spend more time in jail, and have a harder time getting employment. Simply providing housing does not solve the problem for the homeless with mental illness. They also need peer support, vocational training, and skills training. The PATH program, or Projects for Assistance in Transition from Homelessness, funds community-based outreach, mental health, substance abuse, case management, and other support services. Limited housing is available, but PATH usually works with existing housing services in the community. Access is Access to Community Care and Effective Services and Support demonstration project. It was initiated in 1994 by the Center for Mental Health Services. Its purpose was to assess whether more integrated systems of service delivery enhance the quality of life of homeless people with severe mental illness through the use of services and outreach. It was a 5-year demonstration program in 15 cities in 9 states that were representative of most geographic locations. Each site provided outreach and intensive case management to 100 homeless people with severe mental illness. Positive results showed increased social support, less psychotic symptoms, fewer days in the hospital, and fewer days of intoxication when there was a positive relationship with their case manager. The rate of mental illness in the jail population has been rising faster than that in the general population and is estimated to be 5 times higher. 13% of those in jail have a mental illness. Some factors for those with mental illness being jailed include deinstitutionalization, rigid criteria for civil commitment, a lack of adequate community support, economizing on treatment for mental illness, and the attitudes of police and society. Criminalization of mental illness refers to the practice of arresting and prosecuting mentally ill offenders, even for misdemeanors, at a rate 4 times that of the general population, in some sort of institute where they might receive needed treatment. However, if these people had treatment, they may not be doing the things that get them arrested. Decarceration, or decreasing the numbers of those in jail, happens because of overcrowding and the expense of keeping people in jail. Around 350,000 people released have mental illnesses and need to be in the mental health system where they can get treatment, structure, and support. However, this also requires funding. There is also a public concern about the danger of those with mental illness. There's still a lot of stigma in the general population, largely because of the way the media portrays any violent criminal act by a person with a mental illness. While some people with mental illness that don't take their meds have a greater risk of being violent, most of the mentally ill are not a danger. Still, the general population sees the mentally ill as someone to be scared of, avoided, or put into an institution, so there is public support for incarcerating them. Those with a mental illness in the criminal justice system face several barriers to reintegrating into the community: poverty, homelessness, substance abuse, violence, victimization, and self-harm. Some communities have mobile crisis units that are linked to the police department. They're called to the scene after it's been stabilized if the police think mental health issues may be involved. Frequently, the person can then be routed to appropriate services rather than put in jail. They may also educate the police on recognizing mental illness and help change attitudes about it. In Indianapolis, we do have what are called CIT officers with the police force. CIT is Crisis Intervention Training, and these officers do respond if they suspect that mental illness is involved. An interdisciplinary team is useful when looking at the multifaceted problems of patients with mental illness. Different team members have different areas of expertise, and the team can collaborate to meet the needs of the patient more effectively. Team members usually include the pharmacist, psychiatrist, psychologist, nurse, social worker, occupational therapist, recreational therapist, and vocational rehabilitation specialist. Team composition may vary from facility to facility. When working together as an effective team requires the development and practice of several core skill areas. Interpersonal skills include tolerance, patience, and understanding. Humanity includes warmth, acceptance, empathy, genuineness, and a non-judgmental attitude. They need to have a knowledge base about mental disorders, symptoms, and behavior. Good communication skills. Some good personal qualities like consistency, assertiveness, and problem solving, teamwork skills, and risk assessment and risk management skills. Public health nurses who work in the community provide mental health prevention services to reduce risks to the mental health of individual people, families, and community. They might provide primary prevention through stress management classes, secondary prevention through early identification of mental health problems, or tertiary prevention through monitoring and coordinating services. The practice of public health and home care nurses includes caring for people and their families with issues like substance abuse, domestic violence, child abuse, grief, and depression. Mental health nursing changes as healthcare changes. The focus in healthcare in general is to move away from hospitals and into the community. Mental health services are also moving to other non-traditional settings like jails and homeless shelters. The nurse may not have the backup services they're used to, like a doctor, medical supplies, and so forth. The nurse must be more autonomous in these settings. Allowing people to make their own decisions about their treatment is an important part of their recovery, but it's very different than the traditional idea of the psychiatrist or treatment team deciding the best course of treatment. It's the nurse's role to support the patient and to educate them, even if they think the patient's choice is not what's best. It can be frustrating to work with people that have persistent and severe mental illnesses. It can be difficult to develop a therapeutic relationship with them, and the nurse may feel rejected or inadequate if the patient doesn't engage with them.